So thank you for having me here. I'm honored to be here with you today. So my former boss talked about radiological prognostication as tasseography. So like divination is a form of fortune telling, since when you firstly look at a CT scan at the first CT scan, you usually can say just a little bit about what's going on after, especially if the CT scan is pretty much negative or there is just some few things going on. And so we all know how going on. Okay. So we all know those figures, pretty much everybody knows that TBI is it's a burden for the whole world, but most of the trauma-related deaths happens in low-medium income countries. So this is a huge burden. And while we are doing something and for the prevention, there is a huge rise of road traffic accidents and TBI related. The cost of healthcare is usually it goes on patients, and the lack of training, equipment, and the lack of personnel trained to bring patients to the hospital usually has a severe influence on the final outcome. So I wonder how many of you in how many of your departments radiology reports do basically do a CT report with a score inside of it. Can you please? No, nobody? Yes? Okay. So in my department, this doesn't happen yet. We know there are at least 4 major CT score. We know the Marshall CT classification, the Rotterdam, the Helsinki, and the Stockholm. The last 2 of them are quite new. The Stockholm is a little bit more complicated to make, and while the Helsinki is quite easier, and for us neurosurgeons is somehow better because it differentiates between pathologies. The Rotterdam and the Marshall are very well known and used and validated. So another thing I wanted to mention is elegant work done by Dr. Toth from Hungary. It's a PhD work, actually. So he saw that the asymmetry in the first CT scan of the lateral ventricles, so the ratio between them, was predictive of a midline shift development afterwards. So this is a quantitative CT assessment. Not everybody can do this. It needs a software, so in its volumetric reconstruction. So it's not something that we can do on a regular basis in a regular hospital. And to speak about MRI, so the last time I asked for an MRI in a trauma to my radiologist, you may have heard him laughing from here. So this is something that it's really unconventional, both in the acute and the post-acute trauma. It's very useful if the radiology and the clinical does really match. But we know that time is brain. So what do we do? Why did I start to think about this kind of argument? Is that in my region, I was working in the blue area, okay? We are, as you see from the numbers, lucky, simply lucky. So we have lots of district and provincial hospitals. We have 4 hubs, more 1 pediatrics, and we have facilities for rehabilitation. So, and the population is not that huge from, like, if we compare it to your populations probably. So even in this reality, when I reviewed the decompressed patient of the last 5 years, which are 30 in this caseload, because they are the only patients which medical records were complete. So I still found that some patients coming with non-severe or like GCS of 14, 13, were dying. Were dying after decompressed craniectomy because of neuroworsening. So I try to break the argument in many steps. So the initial part, the surgical part, the radiological part, the anesthesiological part, and the outcomes. And what I saw is that the Helsinki CT score performed way better among all the others CT scores, and that the CT-based optic nerve sheath diameter is it's a powerful tool if used, as I think, constantly. So it takes a learning curve from the radiology and from the neurosurgeon as well. But it's a tool, and it might be used to identify those patients whose neurological status is still good, but they might be prone to worsening. So in this, back a moment. So in this, the orange part, the radiological part, we saw that the optic nerve sheath diameters was not important on the CT scan as a mean, but as a difference between one side and the other. Somehow it might significate that there is some kind of pressure building in one side or localized mass effect, and you can predict if there is a ratio between one side and the other. It can predict further evolution and trigger transfer. So I would love to use this if it's validated as confirmed, as we're trying to do now with the prospective study, as a tool for triggering transfer earlier from the spoke hospital to the hub hospital. We know also that we have a huge tool, which is the impact score. It's quite available everywhere from a website. And this gives an early prognosis in traumatic brain injury, and it works very well on large cohorts, not on the single patient, but it's very useful to have an idea. And we have to be aware that there is a diagnostic divide. So you can expect all places in the world to behave in the same way. We know that the WHO has issued many reports on the basic needs of every country on the radiology point of view. There is the implementation of global radiology, but the registry are still incomplete. So we urge you to help radiologists as well, and to advocate for your needs with radiologists and with the state. So about the ONSD, so Dr. Tirsit already did a wonderful job explaining the ultrasound-based, and the CT-based is something that many of you in Karachi are using. So I'm seeing lots of publication about it, and I'm glad. What we need to do, as for concluding, is bridging the divide. We need to integrate and standardize radiological report in trauma protocols. And this is good both for clinical needs on the long run and for research to level the language. The consistency of reporting the catchment area is when more than one hospital can lead to better outcomes, as protocols do. We need to advocate for our needs as neurosurgeons, and we need to do it in a consistent fashion, possibly with also political side. And we need to take a look to affordable possibilities like the ultrasound, like pupillometry, and that the radiologist's value is in the time saved, and sometimes, like in time is brain, also in life saves. Thank you.